welcome WuXi, Program Chair, Vice President and Head of Content, WuXi AppTec, to kick off the online event.
Good morning, good afternoon, and good evening, everyone. Thank you for joining us today for the WuXi AppTec webinar series on collaborations that transform. This is our 11th episode, and it's my pleasure to welcome you. Today, October the 10th, is the World Mental Health Day. We put together the program to honor this very special Awareness Day and to support the World Health Organization's initiative in making mental health and well-being for all a global priority. Mental health is one of the most neglected areas of global public health. Close to 1 billion people are living with a mental disorder. 3 million people die every year from the harmful use of alcohol. And every 40 seconds, one life is lost to suicide. People with mental disorders experience significantly higher rates of disability and mortality. However, very few people around the world have access to quality mental health treatment and care. As a proud supporter of the WHO Comprehensive Mental Health Action Plan 2013 to 2030, WuXi AppTec recognizes there is no health without mental health. Mental health deserves as much attention as physical health as well. Today, we bring together across borders and time zones some of the world's leading experts at the forefront of tackling this global challenge. This is an opportunity for us to address unmet needs, to reshape our thinking, to strengthen global collaborations, and to empower people affected by mental disorders. Thank you for joining us today. Let's tune in now.
Mental health is an integral part of health and well-being. However, mental health conditions are highly prevalent and largely undertreated. Globally, 1 in 8 people live with a mental disorder. 71% of patients do not receive mental health services. How can we work together to address all the critical challenges in mental health care? What are the most important things to prioritize? Please welcome Kara Altimus, Senior Director, Center for Strategic Philanthropy, Milken Institute. Daniel Fung, CEO, Institute of Mental Health in Singapore. And John Crystal, Chair, Department of Psychiatry, Robert L. McNeil, Junior Professor of Translational Research, Yale University.
Welcome, everyone, to this plenary session. We're thrilled to join you today. My name is John Crystal. I'm the Chair of the Department of Psychiatry and Professor of Psychiatry, Neuroscience, and Psychology at Yale University.
Hello. I'm Kara Altimus. I'm Senior Director in the Milken Institute, Center for Strategic Philanthropy, and Managing Director of a new organization, BD Squared, Breakthrough Discoveries for Thriving with Bipolar Disorder. I'm pleased to join the two of you today in conversation.
And hello, I'm Daniel Fung. I'm a child psychiatrist from Singapore. I'm the Chief Executive Officer of the Institute of Mental Health, and also the President of the International Association of Child and Adolescent Psychiatry and Allied Professions. Great to be here.
So today we're going to try to discuss what we think are the critical opportunities and challenges at this transformative moment in mental health care, and to share some thoughts that we have and learn from each other during this brief plenary session. So I'd like to throw the floor open for our group to share some thoughts on this topic.
I can jump in. As we've just started a new major investment in bipolar disorder specifically, as we were getting started in that space, we were astounded by some of the basic statistics around just bipolar, but they fit within a broader context of mental health, where 70% of individuals are estimated to be misdiagnosed prior to receiving an appropriate diagnosis of the disorder. If you look at the duration of time between symptom onset and the actual diagnosis for point of treatment, you're looking at a 7-year average delay. And there's a lot of evidence that's developing that shows that the time between symptom development and appropriate treatment actually leads to a worsening of the disorder. And while I highlight bipolar disorder, we know that that's true across many of the mental illnesses that people are experiencing, and just highlight the amount of work we have to do, even at the very front of how do we diagnose, how do we understand what are our available options for treatment. So I think it's a starting point for the discussion of where are we, and what is the mountain that must be surmounted.
I think bipolar disorder is a great place to start because it's a highly heritable disorder. And so that suggests that maybe if we really understood the neurobiology or how the genetics of bipolar disorder translated into the pathophysiology of bipolar disorder, that we'd probably have some really important new ideas about the treatment of bipolar disorder. But also because bipolar disorder can be such a heterogeneous condition, with some people having just recurrent episodes of depression as bipolar, and other people having mixed, complicated affective states, and yet other people having more traditional classical cycling of mania and depression, that we have little ways, we don't really have the tools we need to understand why different patients are having these kinds of different syndromes of bipolar disorder, and the hope that we would not only have a deeper understanding of the biology, but that there would be biomarkers or tests or ways of figuring out prospectively who's going to follow different kinds of courses of bipolar disorder. Because I think one of the opportunities that will be evolving is to truly deeply understand what an individual is going through in terms of their own neurobiology and their life experience, and then targeting biological, psychosocial treatments, other kinds of interventions to have a greater personalized impact for that person and potentially even change the course of their illness. I mean, these are dreams, these are hopes, but there's no reason why neuroscience should be excluded from the idea of prevention and disease-modifying treatments. That's just a limitation of the science at the moment.
Absolutely. Daniel, I'm interested from the perspective of a hospital, a full care system, as you think about heterogeneity and even the biology underlying, how does that intersect with access?
Yeah, thanks, Kara. As I was listening to you talk about bipolar, and I think very deep, we go very deep into the illness side of the house, and it's important. I mean, identifying different treatments, having new treatments, as John suggested, is important. But we know that treatment gap, I mean, in well-developed countries, relatively large, but in developing countries, and certainly in Singapore, it's above 50%. Even for a condition like bipolar disorder, they are getting to treatments late. They take a long time to decide because of various factors. Some of it has to do with stigma. Some of it has to do with access to care. And I think that when we think of treatments and research around treatments, we also need to think, do we already have existing good treatments? How do we get those treatments to the person and to those who need it, and gets it quickly to them so that it will reduce that morbidity and mortality, so that primary, secondary, and tertiary prevention is quite critical. And that's only on the mental illness side of the house. I'd like to also suggest that we have a lot of work to do in the mental health side of the house, where well-being, first of all, people who develop mental illness, recovery is not just about treating the symptoms. It's also about finding ways to get them back on their feet, back involved in society and relationships. And there's very little research around recovery and what works and well-being. And I think that's where I suppose some of the greatest needs need to come from? And then, of course, who can do this, right? What are kind of resources do we need? The money that goes into research, but also the manpower that we need to develop in this sort of world that we've got.
I think this point around we want to help patients be well is critical. We did a survey, it's been a couple of years, of people living with depression and bipolar, and asked, what does wellness mean to you? And one of the most resounding messages in that survey was that people were communicating, I'm not looking for the absence of illness, I'm looking for the presence of wellness. And so there was a real almost split of, I don't want to not be sick, I want to be well. And I think it's something that we've held on to as an organization, and as we've built initiatives moving forward around, how do we mark what is success? It isn't the absence of symptoms, it's the presence of being well. And that should happen, if we're thinking of a spectrum, it's actually asking for more than just not being sick. It's being your whole self. I love this idea around thinking about the infrastructure of what we need, and building all the way from understanding of what is mental health, what is mental illness, what are the biological targets, how do we follow and understand trajectories, all the way through how do we provide meaningful care to individuals. And I think as we, as a society, as a global society, build the infrastructure necessary, we need to be thinking about the whole pipeline, and how do we build, and what infrastructure is needed to build and accelerate from understanding all the way through access, and not allowing that to be 17 plus years. How do we squeeze that way down so that we're able to translate findings that John's talking about all the way through care around the world that Daniel's talking about?
I think we all want to be well. We all want to be healthy, and historically, an overly medicalized model, I think it has led us to discount the aspirations or hopes of our patients with regards to achieving recovery and wellness as a priority. I think that there are some structural problems that we're going to need to wrestle with if we want to address this challenge. For one thing, there's a siloing or a fragmentation where mostly governmental institutions are supporting research on community-based recovery, and mostly the pharmaceutical industry, with certain governmental and foundation support, are identifying novel treatment targets. But there's really quite a disconnect between the process involved in the developing and validating new treatments and new biomarkers, and a lot of the community-based work that's been focused on wellness and recovery. So that, just to give an example, that most of the drug development research tends to focus on short-term symptomatic outcomes, as opposed to the kinds of recovery-oriented outcomes, which often take much longer and different kinds of structures in order to evaluate. So we really often don't know whether our medications have any differential effect on the overall path to this kind of wellness when we're developing them, or what from a biological point the predictors are that differentiate somebody who has symptomatic but not overall recovery. This has received the greatest attention in schizophrenia, where negative symptoms and functional recovery, at least in the United States, has been built into the process of evaluating whether new treatments get approved by the United States Food and Drug Administration, the FDA. And in some ways, that's a foot in the door, the beginning of a process that probably needs much greater attention and new kinds of partnerships to fund this kind of research.
I was going to jump in here and just to John's point, because I think, there's a problem in the way we try to look at the what works best. And I was reading a paper just published in the journal in the American Academy of Child, Adolescent Psychiatry on the effects of Votoxetin on depression in the young. And the main finding was that placebo and Votoxetin was similar. And then, you know, in my mind, I was asking, perhaps we should do placebo treatment, you know, as being almost as good. And this is the problem with the randomized controlled trial. It's looking for solutions that are magic bullet I mean, the solution that that pharmaceutical industry wants to hear. One treatment that works. But we know that in human existence and all our illnesses, there are lots of factors that make a difference. And can we find those factors using the RCT gold standard for research? Should we consider perhaps what may have been science fiction in 1942 when Isaac Asimov suggested psychohistory, and whether we can predict population response to a more global kind of environmental intervention, and perhaps that's where research should be going into, looking at large populations instead of just a randomized controlled trial. Can we take data from populations? Today we have that technology, we have the ability to do this across the world. Of course, we have to get over the privacy and confidentiality issue, but perhaps that's one way to think about how research and the way we look at the data can be transformed.
I'm really excited about this idea, and I have an and to add. You might have heard just recently, BD Squared launched a series of initiatives. So 4 large funding announcements totaling $50 million in new funding that will go out in the next year, and much more than that over the upcoming several. One of those initiatives is called the Integrated Network, and it builds on this concept where we're saying, and it really came from a lot of input from the scientific and research communities, that the one by one randomized control trial was not giving us enough information in the bipolar specific population, partly going back to the earlier part of our conversation around trajectories and heterogeneity, but also to what you're talking about at the moment, Daniel, where we don't have enough information about the whole human and all of the potential signals we could be getting. And so what we've put forth and our funding is a multi-center, large-scale, it's a dual longitudinal study inside of a learning health network. And so just to break down these concepts, the longitudinal study is going to take 4,000 participants over 5 years and track many different assessments. So we'll do continuous monitoring, cognitive assessments, we'll be doing a little bit of imaging, some biosamples, really trying to understand how is the person doing over time in their day-to-day and at these milestone appointments. That will give us hopefully enough data to understand trajectories, how they're doing over time, what are the factors that are contributing. But that's also happening inside their care setting. And so simultaneous with that information, we will be able to collect information about how are they doing across care, what care are they receiving, what is the combination of interventions available to each of those people. And the network then provides support and analysis back to clinicians so that the clinicians are able to improve and standardize their treatment, their diagnosis, and then learn from and improve the care of those individuals over time. So at the level you're talking about, Daniel, you could imagine that we take this 4,000 and we expand it to 4 million, that we start to propagate that up. But I think it's an in-between where we're able to say, John, we don't know what the trajectories are. We don't know what the biology is, but let's rigorously figure it out. And we're able to say, Daniel, let's put those findings into practice so that they are useful within your hospital as rapidly as possible. So I think we're really excited about the integrated network because it represents this model that I think really does act as a next step bridge to move basic discovery all the way into improved care.
I was going to add that now with the technology and this whole field of digital mental health, we have the opportunity to look at digital biomarkers, which, there's a lot of smartphone data. There is social media, obviously, and then there is also wearables. All of that captures data that today is not fully, I think, the potential of what that can give, particularly in this, the illness group, but also on the wellness side of the house. And just imagine if we had that opportunity, we in Singapore have started as an example, a gamification process for trying to get people to walk more. It's called the National Steps Challenge. And it started with something like 300,000 people. We gave them a wearable. They got people to make a lot more steps towards that 10,000 step a day. And the whole idea is that if you have technology, you can collect data, you can use it as a motivator for lifestyle change. And that in some ways can democratize healthcare, as I see it, that it's no longer healthcare, it's health. And that's something that we probably need to do more work. The National Steps Challenge, by the way, has been published in terms of some of the data that they've looked at. And I think governments need to start thinking about how would we fund things like this away from traditional research.
Well, I prefer to think of it as complementing or augmenting traditional research, because there are things that you learn in traditional research that can't be learned in any other way, but there are clearly gaps in what we're learning that would be transformed by taking advantage of the incredible scope of the global clinical mission. And the notion, the phrase that Kara used, the learning healthcare system, is really critically important. And it rests on what has been a fundamental gap in psychiatry, which is the use of formal assessments of patients to evaluate the effectiveness of care. Care, whether patients are getting better or not, is invisible to many, if not most, healthcare systems because they don't measure the outcomes of treatment. And if you don't measure the outcomes of treatment, you can't evaluate whether the treatments you're offering are helpful or not. But once you start evaluating the outcomes of treatment, which can be done efficiently using some of the digital technologies that Daniel was referring to, then that creates an environment where healthcare systems can be held accountable for the outcomes of care. Plus, it creates the opportunity for the kind of large-scale clinical research that really informs what the true population of patients is experiencing.
One of the topics that you guys have both, and maybe all three of us have inadvertently touched on, is what funding sources and different types of partners are able to do. And it strikes me that without saying it directly, we're kind of talking about how different sources of funding are able to shape and direct and kind of point towards the kind of progress we want. And that there's value, and then thinking about how do we help those sources collaborate or partner in more intentional ways. And I'll throw it to you guys first, but it seems like you might really be at the center of that in a hospital setting, or have seen it throughout research.
Well, I was going to say that there are some models for funding. The national funding bodies tend to now suggest, at least in Singapore, the need for collaboration across various sectors, and the chances of funding approvals are better when you collaborate. And Singapore is a small city, so just imagine if there's some, if everyone gets together and say, let's fund things that make sense for the bigger picture. I think apart from the funding from governments, which is, there are some things that governments cannot do. Very novel or even interesting ideas. Sometimes there is a possibility of crowdfunding, or what I believe has not really, we've not really done enough.
I think that there's also an opportunity for convening, taking advantage of the convening power of different groups to bring all of these constituencies to the table. Government, industry, foundations and funders, and academia, slash clinical leadership. And so there are some groups that have tried to do this in various forms. I think the key point is that this is really a moment for an evolution of the ecosystem where this kind of collaboration is probably more important than it's ever been before. And so perhaps we have to be more purposeful in the way we think about this. And one of the reasons is because this issue of tackling heterogeneity is just a fundamental, foundational challenge in mental health. It's been an obstacle to the development of new treatments. You know, it's heterogeneity reduces the ability of clinical trials to generate meaningful results. It's been a huge challenge in the delivery of healthcare services. And communicating about heterogeneity has been a challenge in public education as well. If we went to the public and told them what we really know about depression, it would be hard to communicate about what depression really is. It's a condition where you sleep too much or you sleep too little. You have too much energy and agitation or you have too little energy. You have too much emotional intensity or you have emotional blandness, et cetera, et cetera, et cetera. We deal with a world of oversimplification because we haven't wrapped our collective ideologies to encompass and build in this heterogeneity.
Yeah, I think we think a lot about philanthropy as being a catalytic addition, and I think there's a couple places that that we have unique funding sources that are relevant to the mental health system. One of those being pharmaceutical funding or private industry funding that's able to really see where there's market need and work to address that and move quickly and in a focused manner to drive sustainable innovation. When I think about philanthropy, I think upstream of that, that what's happening in the private industry, where you're able to have a source of funding that is both more risk tolerant than maybe the private industry funding, but also more nimble than what we see government funding doing. Right. And so that combination of risk tolerance and nimbleness, I think, as we are going to kind of watch the mental health space develop over the upcoming years, is going to be critically important to push the initial innovation forward so that you're able to have almost a bifurcation of government funding and private industry funding that pushes innovation, but also scales that effectively. So we're, as we are just at the beginning of this adventure with BD Squared focused on bipolar, we really are seeing this initial $150 million investment as key to driving these points of innovation. And we're really asking ourselves, what is philanthropy doing differently? How are we setting ourselves up for success across sectors and partnerships in the future?
Yeah, I want to follow up on a couple of things that you said, which I think are extremely important. First, that philanthropy, there are two kinds of philanthropies. One is ensuring the vitality of the infrastructure of the universities or other settings that are going to do the work that we want to get done. And the second is what is sometimes called venture philanthropy, which is a little bit like what you're talking about, where there's a specific objective in mind and figuring out how resources can be garnered to do the equivalent through philanthropy of the Manhattan Project, right? A second group that you mentioned is the venture capital community as critically important. And I realized that one group that we hadn't included as we thought about industry, academia, government, was the venture capital community, who are critical stakeholders and investors in the the capacity both of industry, academia, and to sometimes in government initiatives to make sure that the work is done, and thinking about how that integration, a better integration of the venture capital community into this whole discourse, it deserves some thought, because it's present in a way that it has never been before, both in the pharmaceutical industry, but also in the delivery of treatment services, that deserves some really careful thought.
Absolutely. I think one encouraging piece that we see within the Center for Strategic Philanthropy is that often the venture capitalist key players are very similar, if not the same key players as some of those that are emerging as philanthropists. And so you will see real sophistication in how people are thinking about and moving fields forward across, at the earliest stages, all the way into real private investment.
Yeah, as I was listening to John earlier, and I want to go back to that point about heterogeneity, because I think that it is a problem in our discipline. It is a problem in trying to sort of pinpoint what exactly is the problem when we have a mental illness, like say bipolar disorder or schizophrenia even, because they're neurodevelopmental disorders, and the experiences of the disorders are very different for different individuals. And we've not been able to point directly to biomarkers that we could say that this is it. And we keep looking and widening the net. But this is an important problem. Part of it has to do with the fact that we have delinked, research and clinical work. And what we've been suggesting, and what John, you kind of said, is maybe that needs to come together. That we collect data that is clinical in nature for the treatment of the individual, and then the individual says, look, this is my data, please use it. It's almost akin to, I donate my brain for research, right? But that's long after you're dead. What we want to do is to continue that you are the living example of something that we could research on, and every person, everyone who suffers from a mental illness becomes the research subject. In order to do this, you need a system that can collect the data and make it really simple, and at the same time you consent, you do all those necessary things up front. And I think this is it's very compelling if we can get this out in small communities initially, but as you expand, I suppose in the United States it would be around academic centers where you are doing clinical research and as well as treatment. But I'd like to think that we could bring this whole idea across all the various centers of treatment as a start, and bring everyone together to collaborate. And I think technology is probably the only way we can do this well and simply. And telehealth, telepsychiatry used to be. The whole idea was to really bring that out across vast, areas where remote areas where there are no psychiatrists, and I thought that maybe that's where we should go with some of this research.
This has been a really stimulating and exciting discussion. I think we'll probably recapitulate the points that we made before, which is that this is a moment where we're just beginning to get I'm happy to begin. A deeper understanding of the neurobiology and of mental illness, and at a deep molecular, cellular, and circuit level, and that there's a tremendous opportunity in identifying related novel therapeutics that work through previously unappreciated mechanisms that could have a transformative impact for the unmet need of ineffective pharmacotherapy for patients. But the issue that I raised earlier, dealing with the heterogeneity, that's something that's not a short-term issue. That's not a short-term priority. That's really a longer-term priority, because it's I think a foundational challenge for our field. I don't know if anyone else wants to contribute on their part.
Yeah, I think as we zoom out and we say, what are the big priorities we need to have moving forward, building on all the points that John has outlined about really the complexity of illness, I would say we want to add to that a real determination to bring patient decision-making and voice all the way through the work we do, beginning to end, at all levels of decision-making. We must identify and be steadfast in collaboration across both sectors and key players. And then I'm going to volley this one up because I'm betting that Daniel will add to it. We must be able to think about how do we build the right infrastructure to go from the basic science and clinical questions of what is happening biologically that John's talking about to accelerated interventions and options for people living with serious mental illness to not only prevent or make them okay, but actually allow them to lead the lives they want to lead and be well. And we, as kind of architects, we have to think about what is the right infrastructure to really facilitate that around the world.
Thanks, Kara. I have 3 points, I guess. My 3 points are that I think we need new ways of understanding populations, and we probably need to resource ourselves differently from just clinical care, where there is a professional and then a patient kind of a relationship, to a collaborative, community-based approach. And then finally, I think we need to include mental health literacy in the education of our schools, and then eventually entire populations would be literate and be able to exercise their personal rights as well as their responsibilities in contributing to the new knowledge that's necessary to improve mental health and not just treat mental illness.
Well, I think we're about out of time, and I want to thank all of our speakers for really great discussion, and thank all the people who are watching this for their interest in the topic today, and look forward to the subsequent sessions.
Thank you to John, Kara, and Daniel for your call to the urgent attention to address mental health. Now let's turn to our industry's efforts in developing effective new treatments for patients with mental illness. This has been a very challenging area. However, researchers and drug developers are making strides in the world of mental illness, and a number of therapeutic approaches are promising. What are the most exciting therapeutic mechanisms and targets in progress? How can we overcome the challenges in the clinical development for new mechanisms? What does the future hold for the development of new therapeutics? Please welcome John Dunlop, Head of Research and Development, NIMRA. Mulali Gopalakrishnan, Global Head, Neuroscience Search and Evaluation, Corporate Strategy Office, AbbVie. Barry Green, CEO and Member of Board of Directors, Sage Therapeutics. Ekaterina Malievskaya, Co-founder and Chief Innovation Officer, Compass Pathways. Brigitta Roberson, CMO, Dialyx Therapeutics. And Lauren Martz, Executive Director, Biopharma Intelligence, BioCentury.
Thank you, everyone, for joining us today to discuss the therapeutics approaches toward mental health R&D. To get started, I wanted to jump right into a discussion about the overall innovation landscape. Murali, I'd love to hear your pharma perspective on how investment and interest in neuroscience drug development has been changing.
Thanks, Lauren. Appreciate being on this panel, and thanks for the question. And roughly a decade ago, big pharma sort of de-emphasized neuroscience to varying degrees. But over the past 5-6 years, what we have seen has been a resurgence here with several companies coming back in the space, initially in the space of neurodegeneration, and more recently, investments being made in mental health disorders. So the landscape is changing. And if you look at some of the recent metrics, at least there have been a dozen companies or new companies that have emerged over the last 3-4 years advancing traditional therapeutics in the psychiatry space. And you'll hear later, but there are at least 60 companies that have actually mushroomed in the psychedelics-inspired space. And pharma companies such as mine and others have re-emphasized that psychiatry is going to be an important area for investment and the future growth in the neuroscience franchise. And this is really good news. And the way I look at this, Lauren, is that there are 3 factors driving this renaissance. One is the realization of the unmet medical need, which actually got amplified during the COVID period, particularly the consequence, the significance, the importance of mental health. Everybody tended to appreciate that a lot more. Second is the realization that we now have better tools in our armamentarium, digital tools, other technologies that we'll touch on, that allows us to collect data in real time without additional burden to patients, for example. That now helps us with better trial execution and also opens the doors to some extent in a future world of, I would say, precision psychiatry. And this will be something, again, that we'll cover during this panel. And thirdly, the last point to make is that assets that have been sort of sidelined over the last several years have reemerged with new mechanisms giving rise to new proof of concept results, whether it's the muscarinic approach in the case of schizophrenia or the psychedelics-inspired approach for mood disorders. So it's an exciting time, and we, at least from a pharma perspective, we expect that the investment dollars will continue, provided there is good science and good assets to follow.
Sure. And so, Barry, Murali mentioned this unmet need in mental health. Can you elaborate on that and how renewed interest may help address it?
Yeah, Murali said it well. Mental health or brain health diseases are actually the leading cause of disability in the world and cost the global healthcare system about $500 billion. That's $500 billion to try to keep people well. Everything from depression to movement disorders to neurodegenerative diseases like Alzheimer's. And just to put a fine point on it, I think we all know a family member, a mom, a college student that's suffering from depression. We all have people in our family that are suffering from Alzheimer's disease. So this is a growing concern. It was bad before COVID, and as you heard from Murali, it's been greatly exacerbated by COVID. And I also agree that this resurgence is good. If let me put a fine point on some of this. If the generation behind us has to deal with this trend that continues to grow, our generation behind us are going to have to deal with parents' issues, their children's issues, and it's going to take significant time out of their working day. We're going to be a whole lot less productive society unless we can start tackling with overall approaches, including therapeutics, some of these growing issues in mental illness and things like Alzheimer's. I think the good news, and you heard this from Murali, is that the ability to understand what's going on in the brain has never been better. It feels to me kind of like oncology did 20 years ago. We have some medicines, they're good, but the pathophysiology of the brain, the circuitry of the brain, our understanding is so much greater now that we really can develop much better medicines for this broad range of brain health issues.
Great. So, I'd also like to get into some of the progress that's been made. We've heard about a couple of therapeutics classes that seem to be promising, but John, what therapeutic mechanisms do you think are the most exciting now, are progressing and looking particularly promising?
Yeah, thanks, Lauren. Maybe I'll start by saying that I think it's really quite an exciting time with the sort of emergence and maybe re-emergence of a number of mechanistic classes that I think have great potential for having impact to patients. And I think the way that Murali had sort of teed it up in terms of it being a resurgence probably isn't a better way to describe it. I think there's really been a re-energization based on some of these new molecules starting to show evidence of benefit in clinical studies. In schizophrenia, we've already heard, I think the muscarinic receptor modulators have tremendous potential as a new mechanistic class that are not working through the traditional dopamine mechanism that's characteristic of drugs that are currently used to treat schizophrenia. And then I would say in major depressive disorder, you have a number of different molecule classes. I would point to agents that interact with glutamate, GABA, kappa opioid receptors. Across each of these, both in MDD and in the example that I gave for schizophrenia, you actually have examples of molecules where we have evidence already of therapeutic benefit. And so I think it really, it's upon us now to really make sure that we can deliver these medicines as efficiently and as effectively to patients. And then also, I think we'll have some good discussion with the panel on the class of agents known as psychedelics, where again, I think there's tremendous potential, but also I think certain things that we'll need to navigate as we look to unlock the therapeutic potential of those molecules. So really a very exciting time. And just to put this into context, it's really greater than 2 decades ago that the atypical antipsychotics were introduced as a novel treatment for schizophrenia. The SSRIs, SNRIs were introduced in major depressive disorder. So it's taken us more than 2 decades to actually get to this now new exciting time that we're in. So really tremendous potential, I think.
And so I wanted to bring up the classic neurotransmitter targets that we all know about. These operate throughout the nervous system, and they can lead to a lot of side effects. And we're talking about new ways of targeting old targets. So I'm wondering, as we learn more about the precise circuitry that's disrupted with in some of these specific neuropsych indications, are there parallel learnings in how we can selectively modulate these kinds of targets? This could be open to anyone, or we can skip this question.
Well, I'll jump in. I think the answer is yes. We've had a revolution in understanding brain circuitry and targets. I think we've all had a revolution on approaches, whether they're neuroactive steroid approaches, peptide approaches, antibody approaches. So we're learning a lot more about how to target, and we have tools. As Murali mentioned this and John got into it, we have tools that we didn't have 20 years ago. Certain measures in the blood, EEG, that we can measure brain activity. So we can target circuits in very specific ways with novel approaches, and then have new tools to measure whether we've got target engagement in ways we didn't before. If you back up overall drug development, outside of safety, the reason that many phase 3s fail is the lack of target engagement. We now can just de-risk that in phase 1s rather than having to wait all the way till phase 3s for a massive failure to de-risk it. I think that's hugely beneficial in terms of investment, capital allocation, and number of shots we can go after.
Yeah, I mean, maybe one point to add to what Barry commented now, certainly there are a set of neurotransmitter receptor-based approaches that, Lauren, you touched on. And there are different ways that we're going to be approaching that. But, maybe if you put a futuristic view of where the space would go, one may want to think about other biology that can be uncovered, potentially disease-modifying effects that can slow the progression of disease, not just deal with symptoms. I think that's where the innovation has to get pushed into further. And I'm sure we'll talk about this during the course of the panel, but I see that becoming a futuristic play where there should be more investment, more approaches to go about doing that.
Completely agree.
And then, Katerina, I wanted to turn to clinical development. What are the challenges for these indications that are sort of disease area wide, and what are the challenges, what new challenges are coming with the new mechanisms that we've discussed?
Yeah, thank you very much, Lauren. And it was great to hear everybody's perspective on the panel. I think that what we're seeing now is the emergence, at least in affective disorder space, we see an emergence of a new class of compounds, rapid acting episodic administration compounds. But starting with clinical development, in studying these compounds in clinical trials, we're using methodology and scales that were developed in 1950s. So for some of these compounds, perhaps randomized placebo control studies are not optimal. And certainly scales, developed in 1950s, 1960s for SSRIs might not be, optimal. They probably don't capture the whole value that is created for patients and the health systems. And we do need to look at, develop new scales. On this path, I think the other value that currently we're missing is the role of real world evidence. And it's not the same as real world data, and sometimes they are used interchangeably. But the real world evidence is the data organized to answer a specific question. And usually it's to complement augment the results of the clinical trials, not in addition to clinical trials. So the questions that might be challenging to answer in clinical trials with these new compounds could be answered with, intelligent, skillful use of real world evidence. And again, here, regulators and industry would need to work together. But also, I think real world evidence would allow us to understand the natural progression of the disease. Patients, after a treatment, even on SSRIs, they go to sort of their natural habitat, and we can, oftentimes they're lost for the follow-up. We don't know what happened to them, and we can attribute the effects to any particular treatment or intervention. Passive continuous monitoring of patients, data collection in a focused, actionable way would allow us to better understand patient experience and what are the pain points that we can address.
So you brought up, it seems like, two issues in the clinical development process. There's the issue of endpoints and the issue of trial design. And
Absolutely.
so I want to get back to real world evidence in the trial design then. So, do you envision something like historical control arms being a way to replace the randomized control studies, or what exactly would address that trial design issue that you mentioned?
Well, I think it depends on the compound. It depends on the nature of the disease. It depends on what data regulators and payers are missing and would like to see. So, again, I think it needs to be done collaboratively in conversations, but I think it's on case-by-case basis. I think the most important thing is to have the standards and assurance that regulators would consider real-world evidence depending on the indication and the compound.
Yeah, I'll give you an example. We've got a program for cognitive improvement, and we're starting with Huntington's disease. So we've got an arm that's a randomized controlled part of the arm. We're using traditional measures, but we have a parallel study on more function and feel, simulators and that kind of thing. So that if at the end of the study we get an X point improvement in cognition, we could say what that means is someone could make a shopping list, go to the store, buy their list, come home and return it. At the beginning of the study, they could do that 5 out of 10 times. By the end of the study, they could do that 8 out of 10 times. So partnering sort of numerical improvements with functional improvement, that kind of creative approaches we'll all need to take in the future.
Yeah, absolutely.
Okay, and then I was wondering what other types of tools could help supplement the clinical development process. I know that there are types of digital technologies. Biggs, what are your thoughts on the other tools that could improve clinical development?
I think I have 3 things: biomarkers, and biomarkers. Our tools, like everyone has said, the technology is advanced. The tools are really the technology and the advances and the ability to use that technology appropriately and creatively. AI, bioinformatics, and the biggest tool we have is collaboration and venues like this where you're bringing together, we always talk about having the right drug going into the right patient at the right time. Well, you also have to bring the right people around the right table and the right topic at the right time. So I want to just say that I really admire what she's doing here and to be a part of this panel, very esteemed colleagues, and very excited about what all of our companies are doing to kind of push the envelope. I think we've got to integrate biomarkers throughout development. And I think the regulatory landscape is actually quite open to this. And they're one of our biggest, I would say, advocates and partners in developing these. There's a lot of talk about precision medicine. And I think we're just at the precipice of precision psychiatry. And I think it's going to be transformative for us because we're going to be able to take advantage of what some of the precision medicine sort of progress has, we can use that to inform our own approaches. So I think, the vision promises to be more transformative. By their nature, neuropsychiatric disorders are complex. So people have brought up, well, our scales are old. That's true. Doesn't mean they don't still work really well. And I see it being able to integrate subjective and objective measures, the things that people have talked about, like wearables, AI, real-time data collection, to complement clinical traditional tools, bioinformatics, And you know what we really have to understand is how our patients, how is the drug working, the biosubstrate. So, you know, that means all of the omics, multi-omics, you know, genomics, proteomics, metabolomics, to get early reads on efficacy, tolerability, adverse events, and link those PK/PD relationships. Monitor drug safety, look at the CYP enzymes, because you know, these things all seem very obvious now, but we're actually not always being as careful and incorporating those things in our trial as we could be. And I think have interaction with the agency early and often. They've approved, I mean, I read over 300 biomarkers are currently in drug labels. Oncology clearly is leading the way. And I love to use oncology as an example because I hear a lot, oh, you know, neuropsychiatric disorders are so heterogeneous and they're so complex and every patient's different. That is true for tumors as well. They have different immunology. So we should do immunotyping. They have different antibodies. Each person has a different background, a lifestyle. If we integrate all of those with the powerful, you know, and harness the power of our AI and bioinformatics, I think we're going to make tremendous progress and be able to start selecting, you know, the right patients for the right trials and designs. We have to really look at longitudinal study designs. Like I think Katerina mentioned, the design is really important, and within subject designs, because we know that, you know, these genetic biomarkers, they're state dependent and they change. So we've got to understand, like, well, what's baseline? What's the range? And what does an improvement or success look like? So kind of begin with the end in mind, I would say. We could talk about wearables and all of the specific technology later. Preclinically, I'm super excited about things like iPSC cells and using cells to develop neurons from patients who have neuropsychiatric illness, and then testing our drugs to look at different cell types like glial cells that might be activated for inflammation, to look at neuronal survival, or dendritic outgrowth, neuroplasticity. That's another place that we really need to understand what's going on with neuroplasticity. Can we get a biomarker for that? Decrease our trial size. We can also use this to monitor for placebo effects. If you combine a subjective and objective like EEG, if someone's hallucinating, saying they're hallucinating versus maybe it's a mild visual perturbation or disturbance, we can separate that out. So it's just really about diving in, being committed, and I think like what WuXi's doing here today, getting together and talking about the best way forward.
So you've talked quite a bit about biomarkers. John, I know that this is exactly what you're working on, developing precision medicines for neuroscience. So what progress has been made in finding biomarkers? You know, we don't hear a lot about markers for these kinds of indications.
Yeah, no, I think Biggs has kind of really made a number of important sort of comments, and I'll just elaborate a little bit on that, Lauren. I think I'm personally very excited about the prospects for precision psychiatry, patient stratification in psychiatry. I think a number of enablers have really come into play in the last several years across a number of different dimensions. What I would start with is just availability of data. So we now have, you know, longitudinal patient cohorts that are more deeply phenotyped than we've had previously across multimodal data measures. And what I mean by multimodal is, as well as clinical rating scales, we would have things like EEG that have already been mentioned, various different types of genetics, genomics, other omics, other measures of brain function. And so that really lends itself to the application of contemporary AI ML approaches. And again, we've seen tremendous advances there. I'd point to deep neural networks just as one. So when you have rich data sources, you need the tools and the algorithms to be able to actually start to make sense of that data. And this is the promise of taking these large heterogeneous populations and starting to identify more homogeneous subpopulations within those that are more similar to each other across these very rich data dimensions. And then I would also just emphasize the importance of biomarkers that's already been stated. You know, I think Barry and Biggs have nicely mentioned, you know, EEG measurements now relatively easy to do and to deploy. very information rich, can be combined with other data sources. The potential to start to develop novel markers that we might measure in biofluids in blood, for example. I'm personally very optimistic about what we might be able to do in the future around proteomics for a couple of reasons. One, we now have the technology to do at scale proteomics on biofluids, and I think we have now the approaches that give us more confidence that what we're actually measuring in those biofluids is what we actually think we're measuring. And of course, the proteome is very likely to be changing as a function of progression of disease, right? Whereas, your genetics are really what you that's the cards you're dealt. But I think the proteome could be very revealing in longitudinal studies. So I think it's the integration of all of these sort of dimensions that really offers the promise for what we're all calling precision psychiatry, but it's ultimately how do we better match the therapeutic molecules that we're excited about to the right patient population that's going to derive the maximal benefit from that particular therapeutic agent. So I think it's obviously it's a very area of strong focus for a company. I think many of us on the panel are very excited about the prospects of this in the near-term future.
If I can also mention, I don't know, I didn't quite hear that it was explicitly mentioned, the role of digital phenotyping in stratification and in addressing this huge issue of patient heterogeneity, especially in affective disorder trials. So I think it's very exciting. It's really, really important to continue the work in developing digital phenotyping, passive continuous monitoring, including semantic analysis, including applications of NLP to understand patient experience and create a better diagnosis. So that's one point I wanted to mention. And also, I think digital phenotyping, including NLP analysis, could allow us, could lead us more into personalized type of care. If you think, for example, about, drug development aside, but, patient care, bringing focus into patient care, you think about talk therapy. There are about 900 different psychological therapies approaches. So if you one-on-one seeing as a patient seeing a therapist, it can take 899 attempts to find the right approach that would work for you. But applying this phenotyping early and understanding patient experience early, you might be able to find the right treatment and the right approach for patient much early in the course of the disease. And that's probably one of the reasons why digital therapeutics were not that successful so far in terms of patient engagement, because they really don't take into account patient subjective experience. So I think it's a very interesting area of development in addition to everything proteomics, genomics, and everything else that was said. I think this is an interesting area that can allow us to address the complexity of mental illness, which includes biological, psychological, and social issues.
Yeah, Katerina, you mentioned this, but it's worth a point of re-emphasis because you said it very well, where many of these biomarkers are going, back to Morelli's point, and digital interventions, I'm hoping that it leads to earlier and earlier diagnosis, because the earlier we can intervene in the disease pathophysiology, the better we can develop tools that can change, reverse, maybe even cure that disease. We all know that, if someone's suffering with depression, stays depressed for multiple years, the likelihood of getting that person out of a depressed state is very, very low relative to a first depressive episode where you may be able to intervene early, as an example. So all this work is not only going to be helpful for drug development, but I believe it'll also be very helpful for patient diagnosis early in the path of disease.
Yeah.
Barry, can I pile on that? Because you just it inspired me to kind of add in the Katerina. I think you and I have a lot of overlap in our thinking. And, as a physician, I certainly didn't enter drug development in an isolated way or for a business reason. This should all be about our patients. And that should be one of the tools, to your point, the Katerina, that we take advantage of. And their experience, their lifestyle, the environment. When you think of cardiac, we characterize What is the pain like? How long is it? What's its duration? When did it start? People know the acute signs. If you're having chest pain, or even for stroke, A, B, C, do this. I just can imagine a day when we'll be able to, someone will go to a family member might notice something, or in your regular checkup, they'll be like, well, we ran your EKG, we did an x-ray of your ankle, and by the way, we noticed your default mode network is a little bit off. So we want you to get a little more sunlight and exercise. So I look for the time when those things will be integrated. And, it's so important that we use the right measurements and that are meaningful to patients, because when you look at pain, for example, they've done some wonderful work in developing biomarkers to predict pain and drug response. The endpoint they used was ER visits. Now, I can tell you some people will go to the ER if they have a tiny little bit of pain. Others could be on death's doorstep. They may never go to the ER. And the trust even of that, and not feeding that into the equation, to your point, the experience is really a missing piece that we've got to really integrate. So personally, I've made a commitment, and we're integrating the patient perspective early in development and throughout development. I even have patients on the teams, to sort of give us insight. And it's been remarkable how you can have 10 people around the table and we think we know the meaning of a word like fatigue, and that is not what it means at all to the patients. So sometimes it's as simple as semantics that take us down the rabbit hole, but really great points.
Yep, great.
So Murali, I also wanted to ask, when we're on the topic of figuring out all of these, how to measure these different aspects of different indications, what role collaboration can play, particularly pre-competitive collaboration, and when we're talking about proteomics or any of these types of measures that seem to be incorporated into clinical trials to some extent.
Sure, that's an important question. And again, we're all working in different companies, organizations, but I don't think the problems we're talking about today is something that we can independently solve. So I think that's a place where we need to collaborate and work together, right? So we all, are developing different drugs with different profiles, but at a fundamental level, when we talk about the biology and the targets, we talk the same language. We're trying to figure things out here. And that's a very fertile place for collaboration. So we touched briefly on, how do you think about the next wave of targets or the next generation of targets in the psych space? And Lauren, you pointed out that currently we are, tweaking with, neurotransmitter receptor-based targets, whether it's acetylcholine, GABA, glutamate, and so on. That tweaking will continue, and there will be further optimizations of those targets, whether you're taking an agonist or an allosteric approach, you're taking something that's more selective or less selective, improving the PK profiles, improving safety. That game will continue on for a while. But then if you dial back, and just coming back to what Barry pointed out, how do we detect the disease early? How do we treat early? How do we change the trajectory of the disease, slowing the disease progression? That area of biology is completely out there that nobody is even tapping into. In the neurodegeneration space, human genetics have been helpful. It at least tells you that, which lamppost to look under, which cell types do you care about, which is more important than the others. So that's been helpful in the neurodegen space, as we think about Alzheimer's or ALS and others. But in psych, I don't think we have that luxury available, at least based on my understanding, right? Human genetics is not really out there at all so far. So, how do we really team up to do that? This is something that we, and maybe we might not be able to solve on this panel, but I think, ideas that we can throw out and discuss. For example, I can think of a couple of scenarios. One, given the enhancements in molecular biology and all the analytics we currently have, and John touched on a few things, single cell, single nuclear RNA-seq, the multi-omics approaches. What can we learn about the genetics, the epigenetics, proteomics, metabolic aspects, for example? Can we really look at all of those combined together and try to define, what psychiatric illness really, is manifested at a molecular level? And then on top of that, layering it with, aspects of neurocircuitry, neural networks and mechanisms, can we layer on top of that to understand it better, not only in normal conditions, but also in pathological conditions? So I think that's another layer of complexity that we need to work through. And thirdly, this has to be all relevant to human disease. we cannot try to figure everything in animal models, and that's not really been helpful in psychiatry, as we all know. So where do we begin that? And I know there was a mention, I think Bix touched on iPSC cells. Are there other approaches like iPSCs, organoids, for example, that helps us to take that step in the human direction and also help us back translate? Because as we are learning more things in the clinic, we should be able to back translate it in some way so that we can come up with the next way of doing it. So again, these are topics that everybody's wrestling with. I mean, so John is wrestling with, Barry's wrestling with, others on the panel are doing the same thing. And that's where a pre-competitive approach may be helpful, similar to what, Critical Path Institute is probably doing in some areas, or the biomarker consortia of the world are doing. I think that's where we need to put the heads together and really work to solve those big problems, because I don't think it's something that a single individual or a team can do at this point in time. I'm sure the others will have good ideas to add to that conversation.
And we do have examples of such approach leading to huge success, and that's the birth of immuno-oncology, right?
Mm-hmm.
This is pre-competitive collaboration, data sharing with a common goal, understanding that the field is so huge and there is room for pretty much everyone to add value. And I think learning from that, of course, oncology is has an advantage of hard endpoints and tumor size and cell count and things like that, which we don't have in psychiatry, in mental health. And that's why I think pre-competitive collaboration should include other stakeholders, not only drug developers, but healthcare providers. You mentioned this incorporating the learnings. So creating the learning health systems in order to inform clinical trials, not from the perspective of drug development and market access, but actually from the perspective of what's needed on the ground, what will be adopted, what is patient perspective. And lastly, I would say incorporating patients in these pre-competitive collaborations in their perspective, because the success is dependent on patients, working together with us. We often talk about partnering with patients, but no one would ever partner with us if we would treat our partners like we treat patients, right? So it has to be a mechanism where patients come to the table, understanding the need for data sharing, for participating in this research and prospective data collection and the value that it creates, and work side by side with industry and regulators. So those are all complex questions, I think, in the mental health care space, but it's all doable, it's all solvable.
Yeah, just to jump in on your point about patient advocates. Earlier, we heard that regulatory scientists need to catch up with some of the biologic insights we have. That's where patient advocates can be very important. It's actually explaining to regulators what matters to them. A patient might not care if some plasma level goes down, but they certainly care if they're in pain or they can't remember where they put their clothes that morning. Those are the things that patients care about, that they can explain to regulators so that we can design the right trials for the things that matter most to patients.
Yeah, I guess I'm sort of, to me, the silver lining in this is really that we're having this discussion. I mean, to me, the regulators have, in some ways, they're more advanced than us because they do see everything across the whole landscape, including oncology, and they have the FDA pathways for biomarker validation. We need to be able to replicate and do a really good job of what we're doing to make the case for our patients, and vice versa. I just feel like the tide can lift all the boats if everyone works together. This is just an example, but let's say the default mode network in EEG. If 10, 15 companies come together and we say, let's all look at this in our trials all at once, thumbs up, thumbs down, and get the data, we can we can accelerate the progress of some of these endpoints, surrogate biomarkers. And, I think that at the end of the day, it is really all about, the survival and the life of the patients and what matters to them. Getting in there early, we need all the different medical specialties. I mean, if you want to look at neurodegeneration and Parkinson's, we know for a fact that from childhood, some of these folks have like a fussy personality. Then they go on and they may have a lot of GI issues or anxiety. And they even go to the doctor for these things. Constipation. they get very anxious. Their families describe them as these things. They can be very driven. Their dopamine systems are never looked at that whole time. And then by the time they get to the neurologist with a symptom, a neurological symptom that people are focusing on, the imaging is done and then they're diagnosed, and already they've lost 50% function of those neurons. So those little things way back in the beginning, even through childhood and adolescence, can have a longitudinal and prognostic result or consequence. So we really have to commit to looking as far back as we can, even in children, but also for things like depression, something can happen in the moment, and we can't ignore that as well. So to me, I think it was really great what you said, Murali. Differentiating between acute and chronic is really important. That should be a huge goal right away. And then identifying those early signals and getting on top of them so we can follow those pathways. And maybe that's how it starts. Is inflammation a result of that, or did it cause that? And without knowing that, it's kind of hard to intervene. So even we have enough companies right here to start a whole new momentum.
And now, do any pre-competitive collaborations exist within the mental health space at this time, or is this something that we need to build? Yeah.
No, there are a number that we could point to, Lauren, that have been established across many of the different stakeholders. Maybe one that I would point to is actually a number of companies getting together to think about how do we validate measures like EEG and other measures that you can make within sort of like event-related potentials or mismatch negativity, these sort of things. So don't mean to get too technical, but groups have come together across companies, across academic centers to think about how we can further validate these types of measures together rather than any one of us trying to do that on our own.
They're probably a little quiet. Maybe we need to brand them more. Like sometimes it's two companies, the NIH and somebody else, kind of getting together, and they're wonderful collaborations, but I think we need to go bigger and bolder.
One example that jumps out is always in the PT's Parkinson's space, the Michael J. Fox Foundation. Everybody points to that being sort of a model that has been helpful in many cases. But I don't know whether there's one in psychiatry that we can point to and say, here is the one that we should take the lead, at least today.
A really good point.
Yeah, that's true. We've got Michael J. Fox, the Alzheimer's Association, the Huntington's problem, but the ones in mental health tend to be smaller and focused on slightly different issues. Yeah. So it's a good point.
I think Murali mentioned critical
path institute.
Critical Path Care Institute. Yes, I think they're doing a lot of interesting things, and specifically in scale validation. And there was some interesting work going on there.
And in their biomarkers, their big PPI database, and it's non-competitive, but as far as sharing the information, but there is a grant competitive kind of component to it to be able to access the funds and support. But I think it's a great example of a starting place for psychiatry or neuropsychiatry. I don't see these as different areas, brain and behavior, brain, psychomotor, motor, psycho. It's all within that same organ, as you said, Barry. So maybe we could work with them.
And so we've touched on a lot of topics. There are some that we haven't gotten to yet, but I'd like to finish our conversation sort of on a high note, and I'd love to hear from each of you just what you think the biggest advances have been over the past few years in mental health research, and also what you're excited about most, from what's to come next. So John, I'd love to start with you.
Yeah, no, this has been a great discussion. Thanks to the fellow panelists for sort of really thought-provoking discussion. I would maybe just re-emphasize a couple of things. We've described already a number of promising mechanistic classes that are making their way through the therapeutic pipeline, and actually, there's good reason to be excited about that for the reasons that have been mentioned. It's been a long time since we've really had sort of new mechanistic classes that are very distinct from the drugs that we currently use to treat mental illness. So I think it's our responsibility to make sure that those make their way to patients, that we develop those efficiently. And I think where possible, continue to think about how we can do a better job of identifying the right patients for these different types of molecules and therapeutic classes. And I think there's, again, to say there's tremendous potential for what we've been calling precision psychiatry. And I think this is an area that we're all very excited about, and we can work together on to kind of realize that. So these are, I think, a couple of things that I'm very, very excited about right now.
And how about you, Murali?
Yeah, I mean, I think John summarized it very well. Again, it's a great panel. The takeaway I have and looking into the future is, sort of the 3 R's, right? I think, John, you captured it well. The right drug or the right target for the right patient at the right time. And that's what we need to do. And there is enough avenues by which we can do that. Collaboration is one huge potential. I know, as it was mentioned, we can lift all the boats at the same time, and this is the right time to do it because the wind is blowing in the right direction. Investors are enthused about the space. There's money that's available to do some of the work. And, this is a good time to think about these sort of things so that we can achieve the mission that John outlined with respect to getting the right drug for the right patient at the right time. And at one point, get to a point of curing mental illness.
Yeah, I completely agree. I'm excited by the fact that the world, maybe for the first time in a long time, has talked about the brain as an organ with underlying biology that leads to the diseases rather than some stigma that it's your fault. That's really, really important to destigmatize all this stuff. It's huge to progress. And then I'm really excited by, and John highlighted this well, new approaches on pathways that we've known about, but different ways of target to develop medicines that actually work fast, with broad benefit risk profiles versus some of the drugs that have worked okay, but had narrower benefit risk profiles. That whole wave is coming. We've seen recent approvals. We hopefully in depression more to come. There's different approaches now for cognition and other mental health, brain health issues. So that's really exciting.
Katerina?
I think what I am excited about is that not only we started talking about mental health, but we started talking about mental health honestly, not kind of as a political slogan, but we all come together as our kind of joint human experience and what we're going to do about this. So I think that the change in quality of conversation, I think, will change the quality of work that is being done in developing new treatments and understanding the role of patient and subjective experience in this and the complexity of mental illness. There are a number of exciting developments in kind of drug development space, and Spravato being one of them. And the several panelists mentioned psychedelics, and it's remarkable that this was not possible. And it was unthinkable 4 or 5 years ago that we would be discussing the therapeutic potential of psychedelics on a panel like that. However, I want to mention that just like with any drug development, just like in oncology or any other discipline, we cannot get ahead of data. We need to be very, careful. The studies are really promising, the signals are promising, but they are just what they are. They're signals, and therefore we need to, develop evidence fast, but not faster. And so we need to be sober, we need to be focused, and we need to be competent so we don't miss the therapeutic potential and the promise of novel compounds for people living with serious mental illness.
And Biggs, do you have any final thoughts?
I'm most excited about the next generation of us and what I see on TikTok, and the people are talking about it and what I learn. And when I hear someone now being able to say, hey, I'm on the struggle bus with my depression today, I need a little break, or I need a hand. And people are starting to step up and to think about depression and other mental illness in a different way with a different lens. And I have to be careful because it can bring me to tears sometimes when I think about that progress and what that means for so many. I'm in the treatment paradigm, I'm most excited to have medications that work acutely. And even if that's the most that happens in the next several years, even this decade, that'll be a tremendous leap forward, because it's in the throes of those dark moments when our patients are at their highest risk and vulnerable. I think we do need to treat these things and have disease awareness and amplify the messages that people are bringing to us, our patients are bringing to us, and have everyone understand that just like stroke, an acute episode of depression or a psychotic break or any of these things, an addiction relapse, those are life-threatening as well. And they're serious and they deserve the same level of scrutiny and attention as a broken arm or, Parkinson's or a tumor. So anyway, I couldn't have asked for more from this panel today. It's really been amazing to be a part of this. Thanks, everyone. Nice to meet all of you too.
Yes, thank you everyone for the great insights and a good conversation today.
Thank you.
Bye, guys.
Bye.
Thank you, Lauren, John, Morali, Barry, Ekaterina, and Biggs for a dynamic discussion on the therapeutic approaches in mental health. Thanks to our improved understanding of disease biology and breakthroughs in technologies such as digital diagnostics and digital therapeutics, we are seeing a significant improvement in mental health care. What are the main challenges in delivering and measuring high-quality care for patients with mental disorders? What exciting developments lay ahead? Please welcome Ben Robbins, General Partner, GV, and Daphne Zohar, Founder CEO, PureTech Health.
We've had an ongoing conversation in GV where we have a lot of oncology expertise in this organization. And so there's been this sort of ongoing debate of how does oncology relate to neuro? Is it that, people say that neuro is where oncology was 10 years ago, and we're going to start finding targets. We also hear skeptics that are saying, no, actually neuro is where oncology was like 100 years ago. We're still like not even sure that we're in like the right, basic biological understanding of how the brain works. And then we hear other people that say, no, neuro is just not oncology. It's just a completely different thing. We're never going to get precision neuro because it's just such a complex organ. There's always going to be sort of some level of uncertainty in neuro and psych it's just going to always be there. We're never going to be able to fully grasp a full underlying biological understanding in the way, at least, that we do in cancer. I guess I'm like, where are we? Are we 10 years away from oncology? Are we 100 years away? Is this a totally different framework?
Yeah, I think to some extent it's probably a different framework, but I actually think there's been a lot of progress in understanding mechanisms and a lot of work that's been done by the pharmaceutical industry to advance new approaches. And I think that there are actually a lot of opportunities in CNS drug development to build on validated mechanisms. So areas where you've actually seen good efficacy data in people, but there's some issue that holds back the class of medicines where you could address it through, for example, drug delivery technologies or somehow tweaking the molecule to overcome the issues. That's actually I want to say easier, but a more tractable problem than trying to predict what's going to happen based on animal models and starting with really early drug discovery. Though I believe that that's also important.
And I guess I'm curious, are there preclinical models that you find promising? Just because I'm never quite sure what to make of preclinical neuro or psych data.
Yeah, the way I look at it is if there's enough preclinical data in enough different models, then that begins to give you comfort. And if that matches with the underlying biology and mechanism, you start to think that this could be, worth studying in people. And then you just have to do the experiment, though, because it is really not a clear-cut translation. I guess in that way, it is very similar to oncology drug development. The preclinical models are helpful. They point you in the right direction, but they're definitely not definitive.
Right. The biology is more complex probably than the preclinical models suggest. I'm just very curious if you're seeing advances in the world of schizophrenia and psychosis as it relates to the underlying biology.
Yeah, absolutely. So schizophrenia is such a severe, debilitating disease. It's diagnosed in late teen years, early adulthood, affects approximately 21 million people worldwide. And we were struck by the fact that all of the existing drugs have basically been building on the same mechanism that's been in play for over 50 years. And so, and those existing drugs, they have some challenges, including significant weight gain, sedation, and Parkinsonian-like movement disorders. So, you know, at PureTech, we were really interested in this, and schizophrenia, unfortunately, is addressed often in places like homeless shelters, jails, and hospitals. So we were intrigued really by the efficacy data around muscarinic agonists, and you know, there had been some work done at different pharma companies, and you know, there was really actually remarkable efficacy, but those agents had been held back by GI tolerability issues that the industry really tried to apply chemistry to solve. So what we did at PureTech was we came up with an idea, which was to couple xanomeline, which is a muscarinic agonist, with trospium chloride, which is a muscarinic receptor antagonist that doesn't cross the blood-brain barrier. The idea being that you would get the efficacy in the CNS without as much of the tolerability issues in the periphery. And this became the KarXT program, which was advanced by Karuna. And I have to say, it took us some time initially to really move that program forward, but we were able to show that it reduced the tolerability issues, and Karuna has been advancing it. They recently had results, and I know that a lot of people in psychiatry are excited about the ability to affect potentially all three symptom domains, and then also without the side effects that you see with other agents. So Ben, given your work in psychiatry prior to investing, you have a unique perspective on the patient need for treatment goals. How does that influence the way you make decisions at Google Ventures?
The world of psychosis is an area of particular interest, just because that's where we saw, or where I saw, a lot of need in my clinical days. And so the thing that certainly we've been spending a lot of time on at GV is trying to figure out kind of what are models that we could better match patient needs to what providers can offer. How do we do these sort of lightweight checks for patients that aren't struggling? How do we allocate more resources to patients that are? How do we escalate care? How do we then de-escalate care? And so these care models that are sort of less based on time of the provider as the currency of care, and more based on the needs of the patient as the currency of care, are things we've gotten super interested in.
And I was curious to ask you about value-based healthcare. It shows real promise in the future, but what are the main challenges that you see in delivering and measuring high quality care in the world of behavioral health?
I don't have a great answer. Certainly payers ask this right now of how do we pay for BH? I don't have a great answer for it. It's complicated, right? Because what we see is that a lot of the sickest people who, they've had schizophrenia for 20 years, they're unemployed, they're in a chaotic social situation. A lot of those people are not using BH services. And then all of a sudden, for some reason, they go to the hospital and they start to get better. And then they use more BH services, right? Because they're developing insight, they're developing motivation they didn't previously have. And so you can't use that. It's really hard to say the goal of BH is to find efficient ways to deliver care and reduce spend. Yes, we want that, but you can't use that in such a clean way in the way that you can do that in some other disease areas. And then you couple that with measurement is from my perspective, it's basically non-existent. We have these scales that we use, these research scales, but they're blunt. I mean, the proliferation of PHQ-9 and GAD-7, that was not the intention of those scales. And it is hard for me to just feel a strong sense that we're moving towards the ability to really identify pockets of great care and high value care by use of just those scales. I feel a little bit like I'm just sort of a naysayer because I don't have a great solution. The way that we will do is look for patients who have BH diagnoses and either just find ways to deliver great care in either a fee-for-service or just PMPM model, because there's some motivated entity, a payer, employer. Or we'll find pockets where there's patients who are sick with BH conditions and they have high medical spend, and then we'll take risk on the medical side and provide BH treatment as a way to reduce medical spend, because they're not getting at this core question of like, what is value-based care in the context of isolated depression? Like, I don't know. That's the most common thing that's happening in psychiatry is isolated depression in the commercial setting. How do you treat that in a value-based way? I don't have a great answer. I think it's a complicated issue.
Yeah, I've been really intrigued also by community-based models, and I think that could be a really interesting approach for providing support in depression. And right now what you see is either somebody is isolated or they're in a hospital or CBAT or whatever. But the idea of designing a community-based approach for mental health disorders where there's support and there's peers, but there's and care, but it's not a hospital. It's not something where it disrupts your daily life. I think that's really intriguing. One area that I think is really interesting there is the concept of the ability to monitor and potentially modulate treatment remotely. And one area that we were following for a while is this concept of these digital sort of fingerprints or digital breadcrumbs. And I was really intrigued by the work that was being done to look at voice as a potential vital sign. I do definitely feel that there's a lot of movement towards remote care, but the capabilities and the tools haven't really caught up to the fact that providers are seeing patients remotely.
Yeah, on the remote monitoring side, I think that space has largely been a struggle. We've seen some success, but for the most part, originally we were seeing a lot of stuff around mostly heart failure. People would have blood pressure cuffs for hypertension. They would have scales for heart failure. The models were really tough because it required, sustained patient engagement with things that were just like not super interesting. But the thing that we've been really focused on is there a way that you could build in remote monitoring that doesn't require the patient to do anything? Ideally, it's passive. I think that's probably part of your interest in voice, so I'm curious about that. And then how do you build some kind of action step that doesn't require, an already strained provider system to start trying to build in capabilities to deal with this signal that some third party is giving them? And so we've been spending some time looking at these closed loop solutions.
Yeah, so what we found really interesting about voices, as you mentioned, the idea that it could work in a passive manner on anybody's phone or Alexa or other device that's already capturing voice. And as I'm speaking, for example, I'm using over 100 muscles, my respiratory system, my brain. Even slight disruptions to any of those systems can actually be read through vocal output and a range of different vocal characteristics. The issue with voice is, in order for the machine learning models not to be biased, you need to have a large, broad, and diverse data set. If you don't, the models are going to be biased regardless of how smart your AI team is. And what we did was we partnered with a group at MIT, the Lincoln Lab, and we helped them to found a company called Sond. And they've now got over 1.2 million voice samples from over 85,000 individuals from 4 different continents, 10 languages, and they have one of the largest health labeled voice data sets in the world. So what they're also doing is research collaborations with pharma companies, medical institutions, and the idea is to be able to identify undiagnosed patients who'd be a good candidate for a pharma therapeutic. This is back to your closed loop idea, through a voice sample, and then you activate them on some sort of a path towards diagnosis and treatment. And then the other is to identify patients within a population of diagnosed patients that would be a better candidate for a specific pharma therapeutic. So for example, this is just one idea. If you knew whether your headache was a migraine or just a regular headache, maybe you'd move towards a different therapeutic approach. I don't know if there's other equally compelling examples that you can think of, but that one seems to me to be a really interesting one.
Interesting. In voice is maybe overly technical, but do you need a sample historically from the person to see change, or can you make diagnoses in just a single sample?
Yeah, I think you could do monitoring and flag something, but in terms of there are a number of different characteristics that are connected to specific conditions, like, for example, depression and even suicidality. There's even some really intriguing data that's been generated that looks to be not just patient specific, which I think it makes this really intriguing. But, obviously, once you start getting into diagnosis, the bar is higher. So, I think it's most interesting to think about this as part of a system, part of that closed loop system that helps to build on other work that's being done by clinicians, and, also that does point you to some care and a therapeutic, whether it be a clinical care model or therapeutic. So I think we're almost time, it's almost time to wrap up, but I was curious, I guess, maybe looking forward, what are some of the areas that we each are passionate about? I think that there's so much more that can be done to help kids, adolescents, and the elderly that have mental health issues, that I'm really excited to see what, groups like yours are going to do in providing a better experience for patients and getting some of the knots out of the system. And, I think that one area that we were working in is pediatric ADHD and the ability to harness things that are a little bit counterintuitive, like games. So we were looking at these first-person shooters, and there was some researchers studying those and cognitive interference processing and gamification of a new therapeutic modality that is now actually approved for treating pediatric ADHD. I think that's really intriguing. We don't see enough, I think, engaging and fun activities for kids that could help with their mental health issues. So I'm hoping that we see more of that. I don't know if you want to say anything else to wrap up.
Yeah, no, I think it's a great discussion. I mean, I think to me that we're moving towards some kind of more ideal model where you can escalate, de-escalate. The thing that I think I have not seen yet is some match of traditional clinical medicine that can escalate into like hands-on, multiple times a week care, de-escalate into coaching and therapy, and then de-escalate even further, especially in peds and geri, into non-clinical things, peer-based solutions, not therapy groups, but like going for walks in the park together, social connectivity, meeting people that are struggling with similar issues, finding meaning through, activities and connection. And so I think the more ideal model moves more in that direction, where it's not that somebody, goes on Psychology Today and meets a psychiatrist and now they're in the med path forever, or they meet a therapist, now they're on the therapy path forever. It's some kind of more cohesive care system where you can move between modalities all the way up into clinical trials for something that's not being treated well by a medication, down into content, games, and even further down into, non-clinical activities. I love the at least early movement towards those more cohesive healthcare systems, although I think it's still early days. On the personalization side, I think the world of mental health is a little bit different, again, than other disease areas, to harp on a point. With behavioral health, it's pretty unusual that somebody is in a single state for an indefinite amount of time, right? People that are depressed are not always depressed. Sometimes they're depressed, sometimes they're not depressed. Sometimes they're a little depressed, sometimes they're a lot depressed, sometimes they're anxious. And so the idea of personalization in mental health care, I don't think it's the same thing as like personalized chemotherapeutics, where you're finding like disease targets for an individual and then that's the fix for their disease. I think in mental health, it has to be something that adapts to an individual over time. I don't think we've gotten there yet. And so the idea that you can take somebody who's depressed and provide them treatment for their depression until they're not depressed, and then do something else that's monitoring. I don't think we've discovered a way yet to monitor somebody fully passively via technology to check for mental health episodes. But the idea that you have somebody who's seeing a psychiatrist and getting antidepressants until they're better, and then they shift into something else, in the current framework, maybe a coach who checks in with the person once every 6 months until they get a little worse, and then it's once every 3 months, and then they get a lot worse, and then the psychiatrist is back. So I think personalization in mental health has to be personalization that changes over time based on the needs of the individual.
Yeah, I think that one of the areas that's sorely lacking in mental health care is the integration between different modalities for monitoring, keeping in touch with patients, during times when they're doing well, to prevent them from getting worse. Just integrating the different modalities that people can access both during times of escalation and de-escalation, I think that would make a world of difference. And I also think that the incorporation of peer and community-based support is going to be a really important next step for mental health care.
Thank you, Daphne and Ben, for your candid open discussions. Indeed, big challenges and big opportunities coexist in the mental health care. With emerging new technologies and new medicines, with the strength of science and collaborations, we envision a world where mental health needs will be met through community-based supports, and where everyone will have an equal opportunity to enjoy better mental health. And together, we make mental health for all a global priority. Please welcome Richard Saul, Head of Boston Office and Senior Advisor of Strategic Initiatives, WuXi AppTec, who will close out our event.
Mental health is a lot more than absence of illness. It is an intrinsic part of our individual and collective health and well-being. More than 10% of the world's population lives with a mental disorder, and about 80% of people experiencing mental health conditions are without any form of quality care. This calls for urgent action and for us to work together to deepen our commitment to mental health and to accelerate the R&D process for treating mental disorders. I hope that today's discussions can not only increase mental health awareness and understanding, but also inspire innovative thinking and collaborative solutions to identify new treatments and improve existing ones. On behalf of WuXi AppTec, I'd like to express my gratitude to the distinguished speakers for all of their remarkable insights. To our global partners, thank you so much for your support. And thank you to our audience for joining and participating from all over the world. At WuXi AppTec, helping patients is at the center of everything we do. We all believe in a future where every drug can be made and every disease can be treated. We all believe that global mental health challenges requires global collaborations and global solutions. We all envision a world in which mental health is valued, promoted, and protected. Thanks again for joining us, and we look forward to seeing you at the next episode of our Collaborations That Transform series. Thank you.